In this video, we are going to talk about chronic kidney disease and the prevention of disease progression. The writer is Dr. Shafiqul Chowdhury, MRCP UK, FCPS, FRSCP, Senior Consultant, Nephrologist, Wollongong Hospital, NSW. Global CKD or chronic kidney disease. Chronic kidney disease prevention is between 11% and 13% of world population. There has been substantial variation in prevalence of CKD, chronic kidney disease, in Australia between 2.3% to 11.1%. Most patients with CKD are at high risk of progression with other comorbid burdens, including coronary artery disease and diabetes. It causes a substantial burden on patients as well as national health resources. Therefore, the pragmatic approach is early detection and effective treatment to slow down chronic kidney disease progression. Current guidelines advocate targeted screening of high-risk populations by serum creatinine to calculate glomerular filtration rate estimation or EGFR, and urine for albumin creatinine ration to detect CKD2. Early detection of CKD will allow targeted therapy to be implemented to slow down progression of CKD to end-stage renal disease ESRD. Hypertension is a major factor for progression of CKD to ESRD, that means end-stage renal disease. The prevalence of hypertension in CKD patients is significantly higher, almost 80% to 85%, depending on stages of chronic kidney disease, than the general population, 28.5%. Universally recommended target BP, blood pressure, in CKD is less than 130 by 80 mm mercury. Recent KDIGO, Kidney Disease Improving Global Outcomes, recommended target systolic blood pressure in CKD is less than 120 mm Hg, which is a challenge for physicians to achieve practically. It has also been reported that intense BP control of systolic less than 120 mmHg in CKD may reduce renal function. Less intensive blood pressure treatment should be considered in patients with frailty, high risk for fall and fractures, very limited life expectancy, or symptomatic postural hypotension. ACEI, that means angiotensin converting enzyme inhibitors, or ARBs, angiotensin receptor blockers, are the first line treatment for hypertension with CKD, particularly in presence of microalbuminuria. ACEI or ARBs slow down the progression of CKD and reduce proteinuria. The efficacy of ACEI and ARBs is comparable. There are growing evidence that use of ACEI or ARBs in mild to moderate CKD, stage 1 to stage 3, is beneficial. In advanced CKD, stage 4 and stage 5, the role of ACEI and ARBs remain controversial. The concern is that ACEI or ARBs in advanced CKD may enhance the decline of renal function. Several studies, including meta-analysis, have demonstrated that ACEI or ARBs are also beneficial in advanced CKD for delaying its progression as well as reducing cardiovascular events. Hyperkalemia hyperkalemia is a major concern in CKD, particularly when EGFR is less than 45 ml per minute per 1.73 mol 2. ACEI or ARBs increase the likelihood of hyperkalemia and discontinuation is common. Recommendation is to treat hyperkalemia with dietary potassium restriction, correction of acidosis, use of ion exchange resin such as resonium or potassium binders such as uh, petriomer substance. পেট্রিওমার ওই নামে তো দেখি না, আছে কোথাও এদিকে। Such as petriomer rather than discontinuation of ACEI or ARBs because of their favorable outcomes in CKD and reduction of cardiovascular mortality. In the case of resistant hyperkalemia, discontinuation of ACEI or ARBs is logical. It is expected to see rise of creatinine following initiation of ACEI or ARBs for their effect on renal hemodynamics. Up to 30% rise of serum creatinine from baseline is acceptable. To verify any change, creatinine and potassium should be checked in 2 to 4 weeks of initiation or dose increment of ACEI or ARBs depending on current EGFR and serum potassium. ACEI or ARBs should be discontinued or dose reduced in the presence of symptomatic hypotension and minimizing uremic symptoms when EGFR is less than 15 ml per minute per 1.73 meter square. The SGLT2 that means sodium glucose cotransporter 2 inhibitors are game changer in the management of CKD. They have become an integral part of clinical practice guidelines to slow the progression of CKD with or without diabetes mellitus. The efficacy of SGLT2 inhibitors have been demonstrated in large trials including DAPA CKD and IMPA kidney trials. SGLT2 inhibitors also reduce worsening of albuminuria, which serves as a prognostic indicator of CKD progression. In the IMPA kidney trial, empagliflozin was safely used with EGFR as low as 20 ml per minute per 1.73 meter square. And in DAPA CKD trial, dapagliflozin was used with lowest EGFR 25 ml per minute per 1.73 meter square. It is expected that it is expected to see acute reversible decline in EGFR within 2 to 4 weeks after initiation of SGLT2 inhibitor. This early decline of EGFR recovers partially by 12 weeks. Thereafter, it attenuates the decline in EGFR. Among non-nephrologists, the initial decline of EGFR may create uneasiness. None of the large trials demonstrated an increased risk of AKI, that means acute kidney injury, in people treated with SGLT2 inhibitors. Therefore, decline in EGFR less than 30% does not warrant discontinuation of treatment. However, if eGFR declines more than 30%, patients should be reviewed promptly to assess volume status and consider reducing the dose of diuretics. Every effort should be made to continue SGLT2 inhibitors for their long-term benefits. If there is any risk of hypovolemia, it is safe to reduce diuretic dose before starting SGLT2 inhibitors. It is reasonable to withhold SGLT2 inhibitors during times of prolonged fasting, major procedures, surgery, or critical illness when people may be at increased risk of ketosis. In diabetic kidney disease, non-steroidal MRA, that means mineralocorticoid receptor antagonist such as phenyridone has proven benefit to slow CKD progression. It can be added to ACEI or ARBs and SGLT2 inhibitors with high risk of CKD progression and eGFR more than 25 ml per minute per 1.3 meter square. The limiting factor is hyperkalemia. Therefore, serum potassium should be monitored regularly. Non-steroidal MRA should be discontinued in presence of hyperkalemia or eGFR in declines more than 30%. Approximately 30% of patients with type 1 diabetes mellitus or DM, and approximately 40% of patients with type 2 diabetes diabetes mellitus develop diabetic kidney disease, which is the leading cause of CKD worldwide. It has been demonstrated in 2 landmark trials such as DCCT and UKPDS that intensive glucose control in the earliest stage of both DM, that means diabetes mellitus type 1, and diabetes mellitus type 2 prevents the development of DKD, that means diabetic kidney disease. After the onset of DKD, intensive glucose control has not been shown to reduce the risk of diabetic kidney disease progression or improve overall clinical outcomes, rather increases the risk of hypoglycemia. Clinical guidelines recommend HbA1c target of more than 7% to prevent the development of microvascular complication. Higher HbA1c target of less than 8% has been recommended for established microvascular and macrovascular complications of diabetes mellitus, older age, long-standing diabetes, and limited life expectancy. In conclusion, optimal glycemic and blood pressure control should be appropriately pursued to prevent rapid progression of CKD. Pharmacological treatment has potential to slow down the progression of CKD. Early detection of CKD has potential benefits on patient outcomes. Cardiovascular risk stratification and lifestyle modification such as cessation of smoking, weight reduction should be included in management strategies. So from this writing, we learned that diabetes should be controlled. Otherwise, if diabetes is not controlled properly, anytime any people can have the possibility to develop chronic kidney disease. So I think this video will make people conscious about diabetes mellitus, diabetes insipidus, and the importance of controlling diabetes. Because diabetes leads to vascular degeneration, cardiovascular degeneration. Diabetes also leads to chronic kidney disease and ultimately leads to death. So I hope this video will help us a lot in being careful about diabetes, kidney, and heart diseases. So thank you very much for watching this channel, and if you like the video of this channel, this is a channel for education and edutainment. If you like it, you can subscribe to this channel. Thank you very much.